KFI AM 640, more stimulating talk. Thompson and Espinoza show. That's Elizabeth Espinoza. I'm Mark Thompson, and we're talking about Joan Rivers, her unexpected passing. I mean, she was 81, but she was in great health.
She was a very healthy 81. Absolutely. I will say this. I mean, of course, age will take its toll, but she had just been on stage, as you mentioned, and everyone said, oh, she was funny. She was taking pictures with everyone. She was so vibrant. Well, she apparently was having some type of procedure for her throat. It looks like it was an endoscopy at an endoscopy clinic. So that's an outpatient scenario. It's not like you're at the OR in a hospital.
I just had one 2 months ago. Remember, I had that.
Yes.
I had a viral, whatever that was, in my my esophageal virus. Anyway, yeah, they drop you off. They put you under. They drop that endoscopy, which is a camera, down your throat to see it, and then they bring you out of it after they've removed the camera and the tubing and all that sort of thing, and you're fine.
Right. But again, this was some type of deep sedation, not general anesthesia where they completely knock you out. But somehow Joan Rivers went into cardiac arrest, and so she was rushed over to Mount Sinai Hospital. And unfortunately, now we have the news today confirming that Joan Rivers has passed away. So it does bring up the issue of, sedation, anesthesia. When should you have it? When do doctors turn away and say, maybe you shouldn't have this procedure? So with us is Dr. Paul Yost, president of the California Society of Anesthesiologists. I've always said, Dr. Yost, that I think you have one of the toughest jobs because it's really that little time span of when you put someone under and back out that makes all the difference. But you have to, you actually, as I understand it, you go through a physical first before you put someone under. Is that right?
Yes, correct. And thank you for having me on. And yes, I would tend to agree with you that, we do have a very, very important job. We're there to make sure that the procedure goes safely and that the patient is as comfortable as humanly possible and that we take into account all of the medical conditions for that patient. We do a history and physical before we start. And then we choose and plan the anesthetic based on what we see with that particular patient and what issues they may have. And we may give a different type of anesthetic or a different type of sedation depending on how sick that patient is or what other medical conditions they might have.
If I know you can't comment on this specific case because we probably don't know a lot of the specifics that you need.
I don't have any details about it.
Right, exactly.
I really don't know.
Right. So my question is, with in general, this endoscopy type procedure in a person of advanced age, what kind of, because I'm losing track of, it's not a general anesthesia, it's a deep anesthesia. Can you give me some sense of what's generally used?
It depends on the situation. It depends on who's giving the anesthetic and what it is that they're giving. A lot of times we'll use either a combination of a relaxing medication like benzodiazepine, like something called Versed, and usually mixed with some type of opiate, usually either fentanyl or Demerol, something like that, because the procedures can be uncomfortable. So you want to make sure that the patient is both relaxed and comfortable throughout the procedure. Sometimes we will use a medication called propofol or Diprivan for sedation for these, that usually in the hands of a trained physician anesthesiologist.
And doctor, but isn't the difference, so people are clear, when you go under general anesthesia, they're breathing for you. When you're in deep sedation, you're still breathing on your own.
Well, sometimes yes and sometimes no. I mean, you can have, a general anesthetic where you're breathing on your own, and we do that pretty frequently. It has more to do with how you respond to the stimulation. Like what we call moderate sedation is when you would respond purposefully to any type of stimulation, like you'd ask the person a question, they would answer appropriately. A deeper level of sedation, or what we call deep sedation, is when you would have to stimulate the patient or do something that's painful to get them to respond. And then the general anesthetic level is when they don't respond to any kind of painful stimulation, and you could obviously, like, say, do surgery or operate on them or something like that. And these levels are not always clear-cut. Sometimes patients can sort of drift from one to the other, and that's why you want to have a trained person that's monitoring that patient to know how deep they are and to be able to rescue that patient should they slip into a deeper level of sedation than what you intend.
I guess none of us were necessarily surprised that an 81-year-old woman has a heart attack when undergoing some kind of procedure that involves anesthesia. But should that...
I would actually disagree with that. I mean, I think there are a lot of 81-year-olds that undergo procedures every single day and do so very safely.
Well, that's exactly what my question was. So you're not. Yeah. So you feel as though that doesn't mean anything. You're 81, you're 85, doesn't matter. Let's put you under and let's get this thing on.
Not necessarily. It depends more not on the raw age of the patient, but the other medical conditions. I mean, you can have a 56-year-old patient that has severe coronary disease and has an aortic valve that's incredibly tight and has severe aortic stenosis, is in congestive heart failure, and is a terrible risk. And you can have an an 86-year-old patient that's out there walking 3 or 4 miles a day and is healthy as anything, and you would have a much lower risk with the older patient in that circumstance.
Let me ask you something, doctor. This was an endoscopy clinic, so clearly they were looking at her throat area.
Right.
Was it possible to do local anesthesia?
A lot of times they will do some degree of local anesthesia, but it's hard because the scopes are fairly large, so you do need to usually use some type of sedation. And then whenever you're putting a scope into the mouth, the vocal cords and the breathing tube is right next to the esophagus where they're going. So it's not super uncommon to sometimes have some degree of stimulation that causes the patient to cough or to buck or even to go into something called laryngospasm, where their vocal cords may close and not open very easily, and in which case you have to give them more sedation or take the scope out, give some positive pressure ventilation, and maybe even do something like, place a breathing tube or something else in that particular circumstance.
Well, as the details come out on this, maybe there'll be more to ask Dr. Paul Yost.
Yeah, and doctor, just real quick, because I think she would always joke about she's had so many procedures for her plastic surgery procedures that she said she would joke. I'm serious. She would quote that they were going to donate her body to Tupperware once she died. This is in true Joan Rivers fashion, right? Yeah. Let me ask you this. Is she more high risk, though, because she's had so many procedures? I've heard they say if you've gone under general anesthesia several times, you become even higher risk.
I don't think so, no. And in fact, if anything, I think it would be a lower risk, especially if you have access to the other anesthetic records, and you can know exactly what they gave and how her body responded to those anesthetics. So I would feel much more comfortable if the patient had other anesthetics, and I'd be able to review those anesthetic records. They're kind of like a roadmap as to how you apply on the anesthetic going forward.
You're my kind of doctor. Can I just say that, Dr. Paul Yost? Sort of like, hey, no problem. You're 80. Let's just take a look. You look okay to me. Yeah, let's look at your records.
But it's not that. It's what does the history and physical show you? What kind of medical history do they have? Do they have any history of heart disease? And then you do your very, very best to minimize those risks. But you try to identify those risks ahead of time, and that's why you want to have a physician anesthesiologist be involved in your care.
No, I get it. Thank you so much. Listen, we appreciate you joining us on short notice, Dr. Paul Yost.
Absolutely.
Yeah,
please, anytime.
California Society of Anesthesiologists. He's the president, and probably no better perspective on at least the anesthesiology associated with this whole Joan Rivers thing, Elizabeth, than what we just got.